Welcome, everyone. We are so thrilled to have you with us this morning. Again, I am Nicole Burnside, our Managing Director of the University of Michigan Injury Prevention Center. I will be guiding you through today's program, so you're in good hands. We have a wonderful lineup ahead, and we cannot wait to share it with you. To get us started, we'll have welcome remarks. Please join me in giving a warm welcome to our Dr. Doug Weeb, co-director and principal investigator of the Injury Prevention Center, and he's also a professor of epidemiology.
Good morning, everybody, and it's an honor to be here and to welcome you to the 2026 Injury Prevention Research Symposium. Thank you for being here for a celebration of scholarship. We have a wonderful day ahead. Before we dive in, I want to take a moment to acknowledge the many Injury Prevention Center staff and faculty who have worked really hard to make this possible. Please join me in thanking them for all they've done. Yeah, impressive team. For those of you who may be newer to our work, let me share a bit about who we are. The University of Michigan Injury Prevention Center is a CDC-funded injury control research center. It's one of only 11 academic centers funded of this type in the country. This center's been funded since 2012, and our center operates through 3 cores: training and education, outreach and translation, and research. Together, these cores work to accelerate injury prevention research into practice and policy, with the goal of reducing the burden of injuries across the Great Lakes states and the United States. I joined the University of Michigan about 3 years ago. My motivation for joining was to continue engaging new injury prevention scientists, leverage the incredible resources across this campus to enhance injury prevention research, and strengthening the work happening in the Department of Epidemiology and the School of Public Health. The field of injury prevention continues to grow, and the opportunity to make meaningful contributions has never been greater. I'm incredibly proud of what our team has brought to this field. Over the last few years, members of our internal advisory committee engaged 140 students across multiple levels, including 5 undergraduate UROP students, 30 master's level students, 27 doctoral students, 42 postdoctoral fellows, and 36 junior faculty. The difference they're making in this field is exactly the kind of impact we want to keep moving forward. Beyond our mentorship, our team has shown up in a big way for the broader injury prevention community. As a key example, in 2024 and 2025, we hosted events for National Injury Prevention Day, bringing together over 110 faculty, staff, and students per year to learn about the field of injury prevention science. Our research enterprise has expanded just as significantly. We have funded or co-funded 14 exploratory and core projects, hosted over 44 students in our summer intern program, and supported many, many more throughout the academic year. A few additional highlights that I want to call out include our research extends well beyond this campus. Injury prevention staff participated in 40 conferences, and members of our internal advisory committee and faculty presented their research at a total of 179 scholarly events in these past 2 years. We were also at Swim Across America, sharing drowning prevention materials, and also at the Black Men's Brain Health event with you, Priscilla and company, among many others. We've also invested in our digital presence. Our updated IPC website now features curated topics, staff bios, and upcoming events, serving as both a practitioner resource and a portfolio of our work. We significantly updated the Checkpoints online program. It's a free tool for parents and teen drivers during their critical first year of independent driving. In addition, we've launched our Injury Prevention Center LinkedIn page, where you can view our conference materials and start following us. And in 2025, we released the Impact of Recreational Cannabis Legislation in Michigan report, led by Drs. Aaron Bonar and Jason Goldstick, which explores cannabis-related injury, social, and health indicators in the context of Michigan's legislation. Back to you, Nicole. All of this reflects the dedication of our center and our researchers that you're going to hear from today. We're extremely proud of this team, and today you'll get a front row seat to the work that they're doing. And I'll turn it back, who will take us through the details of our agenda.
Thank you.
Thanks, Nicole.
You're welcome. Thank you, Doug, for those updates and for always cheering on our work. Now let's tell you what to expect today. So as we move through the day, our program will showcase current and recent exploratory and pilot research projects from across our center, bringing together researchers, staff, students, postdoctoral fellows, and community partners dedicated to advancing injury prevention science. You have likely already had a chance to explore the poster presentations this morning. Thank you to every researcher who shared their work. We also have several planned breaks throughout the day to revisit the posters, connect with presenters, and mingle with one another. The restrooms are located in the atrium in the front by the stairs. In addition, there are gender-inclusive restrooms located past the remote working cubbies and up the stairs on your left. A full lunch will be served later, and we hope you will stay and make the most of our time together. If you would like to learn more about today's speakers or read the poster abstracts in more detail, head to our website by scanning the QR code in your conference program. Just hover your camera over the QR code image and press your mobile phone screen to focus on the one you'd like to capture. You can also visit our website at injurycenter.com.umich.edu. We are also offering 2.5 continuing education credits. To claim these credits, you can find the link in the follow-up email and the QR code in the conference program. Today's program also includes some interactive moments designed to spark conversation and put your voices front and center. We call these moments. The research room responds, because that is exactly what we want, to hear from you in the moment. Throughout the day, you will have opportunities to submit questions during our discussion sessions and connect with your fellow attendees in ways we hope to lead new ideas and lasting partnerships. A few of these moments even come with a chance to win prizes from the IPC team. Let's try it now. Pull out your phones and scan the QR code on the screen. I love seeing this kind of engagement. Thank you for jumping in. And I look forward to learning more about all throughout the day. Let's see, how are we doing here? Unlimited research funding. Yes, we all hope for that. That would be lovely. Yes, you can edit your response. So thank you for the engagement. We'll have a few of these throughout our program today. So with that, let's get into our first round of research presentations. Please help me welcome Dr. Patrick Carter, co-director of the University of Michigan Injury Prevention Center and associate professor at the University of Michigan Medical School Emergency Medicine Department, to the stage.
Thank you, Nicole, for that warm introduction. So good morning, everyone. I'm really glad to be with you here today. We're going to kick off the day here by hearing from a few of our researchers conducting projects here in the Injury Prevention Center. And what you'll hear today represents the true breadth and depth of what we do at the Injury Prevention Center, from the field to the lab to the community. Our first presenter this morning will be and I'll introduce both of them, and then you'll hear from them. There'll be time for Q&A at the end. Is Dr. Colleen Peterson, who is an assistant research scientist at the University of Michigan Transportation Research Institute. A social behavioral epidemiologist by training, Dr. Peterson applies advanced population-level analysis and mixed method approaches to examine issues of safety and mobility. She will be presenting her project exploring ways to counteract distracted driving among young drivers. From distracted driving, we'll turn into another area with significant implications for young people, and that's sports-related concussion management. We'll hear from Dr. Abigail Bretzin, who is a research investigator here in the U of M Injury Prevention Center, and her work examines the epidemiology of concussion and traumatic brain injury and associated health disparities. She focuses on long-term outcomes of injury and repetitive head impact exposure. Her research also engages underrepresented communities with particular attention to differences in sports-related concussion incidents and outcomes across male and female athletes. Today, she'll be presenting her project on understanding concussion management practices. As I said, we'll take questions after the two presentations. We look forward to hearing your thoughts, and I would welcome Dr. Colleen Peterson up for the first talk.
Hi everyone, full disclosure, I'm not a morning person, so bear with me in any stumbles. And I haven't worked on this computer before. Thank you for the introduction. So I don't need to say any of that, but I do work just down the road over there, but mostly I work remotely from Minnesota, so catch me online, email me, it'd be great. So my talk is entitled Breaking the Habit, Exploring Mindfulness Training to Counteract Distracted Driving in Young Drivers. And this is a really important topic because on the road today, crashes are still the leading cause of mortality amongst 15 to 24-year-olds in the US. Just about 50% of the deaths are due to motor vehicle crashes. And a big factor in that is distracted driving. The states across the U.S. have recognized that and put bans on place for handheld use while driving and calls. And a lot of places also have more strict restrictions for younger drivers and novice drivers. And yet, young drivers are still more likely to engage in distracted driving and also more likely to suffer the consequences of distracted driving, as we saw those the rates of mortality due to distracted driving. And why is this? Well, young adults are still in a developmental phase and a social phase that can really impact everything related to phone use and driving. So think about driving and feeling FOMO while driving. Your phone goes off and if you're feeling more FOMO, you might really want to respond to that. There's also a higher prevalence of phone addiction among young adults, perceived lack of control, meaning they just don't feel like they could say no to answering the phone or looking at their phone while driving. And then their prefrontal cortex is still developing, and that's the main driver of decision-making and control. And that doesn't really become fully stabilized until age 24. So this is all to say that distracted driving behavior is a complex and multi-layered problem that it's evident that current strategies are not effectively tackling, especially for more vulnerable younger drivers who, as I said, are affected by a lot of internal and external pressures and also are just kind of newer drivers all around. So looking at the literature and what's out there, I and my colleague, Dr. Renee St. Louis, thought we should explore mindfulness. I've been doing yoga for a little bit and in mindfulness training, and that sort of personal interest piqued my interest in the potential use of it for driving. And looking into it, mindfulness helps one be aware and sort of check impulsive behaviors and also acknowledge and regulate emotions. And those two seem like real big factors when it comes to distracted driving. So we wanted to explore mindfulness training and whether mindfulness practices are related to distracted driving as a real exploratory foundational effort. And I think I just said that. We will describe the relationships between mindfulness practice and traits and distracted driving behavior. And also, most importantly, if we're going to promote mindfulness as an intervention tool? Are young adults open to it? So my colleague and I developed a survey that we distributed across the US, recruiting young adults using a lot of different services and list hosts. We asked people to be included if they were between 18 and 24 years old, have a valid driver's license, and have driven in the last 30 days. Good, okay. So some key things that we looked at in the survey to explore these relationships were asking about the rate of distracted driving behavior, which we defined as scrolling or tapping their phone. We explicitly said that having a phone for navigation and CarPlay was okay given the prevalence of it. We also wanted to look at the stable traits. So 5-facet mindfulness questionnaire gets at that, and I'll talk about that in a second. And then because of the other factors due to young driving and the prefrontal cortex and that kind of thing that I mentioned, we included some survey measures looking at impulsiveness and emotional regulation, and also problematic phone use. And I want to give a little bit of a deeper dive on what the 5-facet mindfulness questionnaire is. So everybody has some level of mindfulness, and it could be lower, it could be higher. But in the literature, they've sort of defined these 5 traits that are kind of more stable, and they live outside of anything like mindfulness training. That's observation, acting with awareness, non-judgmental, and non-reactivity. And I'm just going to highlight acting with awareness and see if everybody will play along with me and try out this thing to see about what awareness is like in real life. So if you kind of do like the OK symbol and think about, without doing anything, think about your pointer finger touching your thumb. Okay, now without doing anything, think about your thumb touching your pointer finger. You're able to sort of feel that shift in your focus. That's awareness. That's like that metacognitive awareness of like being like, I can feel where my attention is and redirect it. And I think that's really cool. Did everyone think that was really cool? Yeah. Anyway, so that's kind of what mindfulness training also kind of gets at, but like not just your thumb, but like everything. We also asked some open-ended questions exploring the acceptability of mindfulness training. All right, so let's look at the quantitative results. And I'll just highlight that we had a really good response from 328 diverse participants. Average age was 21. They came from all walks of life, at least in terms of driving, urban, suburban, and rural. And most had been either licensed for 1 to 3 years or even more. And we asked them to tell us about their current mindfulness practice. And I think we defined mindfulness as being defined as the state of being aware, attentive to, and aware of what is taking place in the present moment without judgment. And we also asked them, do you do any of these things? They could say, select all. So in the end, about 50% of people, 3 minutes, wow, okay. Okay, so I'll just get to the end of it then. Or actually, I actually want to highlight the fact that people were really honest about their distracted driving and had, in fact, suffered some real on-the-road consequences of distracted driving. And what we found when looking at the stability of traits and practice, there were some differences in those traits and practice, but when it came down to it, only the awareness trait was significantly associated with distracted driving frequency, that self-reported behavior. I looked at, again, this was pretty exploratory, so I built a model to look at what was a part of awareness and related to distracted driving. And yeah, as awareness increased, self-reported distracted driving went down, but also motor impulsivity, physical, want to grab things, also predicted distracted driving. And looking at practice, any practice at all was actually counterintuitively related with more distracted driving. But on the other hand, if if in the end mindfulness does prove to be an intervention worth exploring, young adults seem pretty willing to engage in it, suggesting that it could help them focus and reduce road rage and anxiety. They're saying, you know, a lot of young adults recognize the danger of driving and how difficult it is, and they said, yeah, if this helps me be a better driver, I'll want to do it. But on the other hand, we had some good researchers out there, some good scientific-minded people who wanted to see the evidence before they decided it was worth their time. So some study limitations I want to point out is that we didn't actually ask how long they'd been practicing, and we're not sure if their yoga, their use of the Calm app actually really adheres to the idealized mindfulness training. And also, again, like many self-reported surveys, distracted driving and who decided to be a part of this survey could be a problem. And I think I'll just skip that for the next steps. So of course, being a good researcher, I'd like to do more research on this topic, and we'd like to include younger and more novice drivers and explicitly include those questions about duration and sort of get at, what does their mindfulness training look like? And then if all that says, yes, mindfulness is in fact a good idea, we'd want to do a pilot randomization trial with longer follow-up and more objective measures of objective measures of distracted driving behavior. And we'll do the questions at the end. Nice. Thanks for having me, and I hope you remember that cool trick and what awareness can do for you.
Awesome. So my name is Abby Bretzin, and I'm going to be talking about concussion management practices across collegiate athletics programs. And I promise my talk won't be interactive. I won't be giving you all concussions today. Just wanted to orient you to who I am and why I'm doing the research that I'm doing. So I'm from a small town out of Buffalo, New York. So if you need chicken wing recommendations, let me know. But what I did there, I was a high school athlete, and during this time I sustained a sport-related concussion while being captain of my high school soccer team, and that brought me early interest into athletic training as a profession. So I went on to get my undergraduate degree at SUNY Cortland and really got an interest in concussion research at this stage. From there, I wanted to do more training in athletic training as well as get experience in concussion-related research. So I went to Temple University, where I worked as a high school athletic trainer in North Philadelphia. And so if you're interested in this setting, there's a nice documentary of the high school that I worked at while I was there. But I really got interested in sex differences in concussion incidents at that time. And that motivated me to go on to get my PhD in athletic training and kinesiology, working with Dr. Tracy Kovassin, a leading sex differences researcher in concussion. And that really spearheaded my wanting to do concussion research overall. And so I wanted more training in methods, epidemiology, and wanted more experience in public health. So I sought out a postdoctoral fellowship with Dr. Doug Wiebe, working on the Ivy League Big Ten epidemiology of concussion study. And that led me to here working as a research investigator in the Injury Prevention Center. So you can see some of my biases as an athletic trainer and someone with lived experience with concussion, and that's motivation for a lot of my work. Just getting into what a concussion is. So over hundreds of thousands concussions occur as a result from sport, especially at the collegiate level each year. And after a concussion happens, people typically recover from that injury, and this can be variable in terms of time for a given person. What happens throughout that recovery, especially in the sport-related realm, is that athletes are progressed for a stepwise physical activity and integration of daily life along a progressive protocol, which is really informed by a lot of symptoms. And so athletes are following this typical recovery that's often occurring across a month. And there's a lot of work doing how can we improve concussion management and improve recovery outcomes. What we know about this recovery process is that clinicians are generally following concussion management practices that are aligned with current consensus guidelines. However, what we also know is that prevention and assessment approaches can vary based on clinician perspectives and available resources. We know that symptom monitoring is an important stepwise progression. It's very commonly used, but it often relies on paper and pencil assessments that are done in person. And so real-time daily symptom monitoring could be a valuable but underutilized tool in the sports medicine world. And so what our goal of this specific research project is to see if we can improve concussion management overall using remote symptom monitoring. And so we have this platform called Recoups, which Doug developed during his time at Penn, which has been used in randomized controlled trials as well as in dissertation research, where we prompt the patients to receive SMS texting via their symptoms. Those symptoms are then sent to a dashboard that the clinician can view and act upon in terms of recovery and treatment. And so our goal for this project was to see how we can best implement a daily symptom monitoring tool like Recoups. So what would that look like over concussion recovery? The athletes or patients would be given these symptom reports daily across their recovery. They would respond to them, and then the clinician could then view their symptoms and see how they're doing and see if they can progress them to their next step of the recovery process. So the purpose of this specific talk today and study overall is to conduct pre-implementation, semi-structured, qualitative focus groups to help us understand concussion management and identify facilitators and barriers to current concussion symptom monitoring. And our overall goal of this specific project is to inform implementation strategies for introducing a novel daily symptom tool in collegiate athletic settings. For our methodologies, what we did to accomplish this work was conduct semi-structured focus groups with 10 collegiate athletics programs. These took about 30 minutes, and we were really interested in understanding their current concussion management practices, their current roles in recognition, assessment, and decision-making during concussion recovery, their current assessment tools and available resources that they have, and their perceptions of facilitators and barriers in terms of adopting and using new tools in their practice. For our analyses, we did rapid qualitative analyses, and we first did inductive thematic coding, which was to identify themes related to concussion and codes overall, concussion constructs. Then we did deductive thematic coding, aligning with the CFR 2.0 framework, which is commonly used in implementation work, where we ask about the innovation itself. We identify themes related to the outer setting, the inner setting, people on the team, as well as the implementation process. And so we found a lot through these 30-minute interviews, and so I just want to highlight our facilitators first. And if you're interested in more detail, I'm happy to talk about this afterwards. But what we've done is outlined our data along that concussion recovery platform. So in these circles, you can see everything from pre-injury to initial assessment to medical clearance and decision-making, and how these codes were identified across the concussion recovery practice. In terms of facilitators, some common themes that we found is that clinicians do want remote and accessible symptom monitoring applications. They're on the sidelines with the athletes, they're traveling with the athletes, they want to be able to see this wherever they're working, and so they're really open to this type of tool. What we also found as a facilitator is that clinicians are already conducting routine symptom assessments. In the collegiate setting, the clinicians are with their athletes daily. They get to know them at the personal level. There's small clinician to athlete ratios, and so they're already using these symptom tools to bring evidence to the decisions that they're making for referrals, management, and additional resources that they may need. Another common theme that's really good for our project is our clinicians are all already using the same concussion symptom validated assessment tool. Many are using the SCAT-6, which is 22 symptoms that are asked daily in the same athletes, and so it would be really easy to then implement this in a remote option since they're already using the same symptom reporting. And I just wanted, since this is qualitative, wanted to point out something, a theme, is that many of our clinicians were recipient-centeredness, meaning they're thinking about the athlete when they're making the decision. They want a tool that's easy for them to use, that doesn't put burden on them, and something that they will respond to. So that was a really common theme. We also found a lot of barriers or challenges in how to adopt a new tool in practice, and so we outlined those again across the full recovery process. And so just highlighting some of the more common or themes that stuck out to us were that a lot of the clinicians in the collegiate athlete setting are already using a tool where they can accomplish remote symptom monitoring in their practice. We commonly heard something called SWAY, which is a multifaceted tool where they're asking symptoms, they're doing cognition, they're doing balance, and so they use all of these objective and subjective data points to make their decisions. And others have a symptom monitoring tool that could be directly integrated into their EMR, so they don't have to log into something else. All of their symptoms are sent and reported right into the system that they're already using. Another barrier that we found was in the needs assessment itself for these clinicians. So what they're doing is they're seeing how their goals fit their practice and how they can collaborate across the full sports medicine program. And what they're trying to find in terms of using tools are how can they incorporate the standards of care and how a tool that they want to use in the future can conform or be used in conjunction with other tools that they're already using. And so what we also found a lot throughout these focus groups was attention for change. And so I point out here, one of the clinicians mentioned that they really value that face-to-face in-person assessment that they're doing, which is already really common in the athletic setting. And so taking away that face-to-face setting creates a variable that the clinician doesn't have when they would just be sending something out via text messaging and looking on a screen. And so that was, attention for change was a really big barrier we found. I point out this quote just wanting to highlight some of more facilitators and barriers. What really came up throughout these talks is that our clinicians are following policies and guidelines that align with best practices. However, what they're really looking for is something that accomplishes this multifaceted assessment when they're looking for more tools and not just the symptom reporting overall. And so in terms of takeaways or next steps, our clinicians saw value in using Recoups as a daily symptom monitoring tool. However, collegiate athletics might not be the most appropriate venue as they already have daily ingrained day-to-day FaceTime with their athletes. They're already using existing multifaceted tools, and there was a lot of tension for change. And so our next steps are to really do some more pre-implementation focus groups in the high school setting where this daily interaction is not necessarily ingrained and available to them across the board. And so in terms of our research team, I couldn't do this without them. First, thank you, Doug, for the opportunity in terms of research and using this tool overall. Kira Sullivan for your impeccable work on coordinating this project. Dr. Shauna Smith is our implementation science expert on the team. And Dr. Allie Tracy did her doctoral studies at Michigan State and was a really good team member overall. And so I think we can open this up for questions.
So I think we do have time for a few questions if folks have any immediate ones. Oh, there's one standing up. There's a microphone, I think, coming around to you.
Okay, hi, I'm Amanda Esquivel. I'm an associate professor at U of M Dearborn. And I just had a quick question on the first study. When you did the survey on mindfulness, was there a difference between men and women in answering those questions? Did you look at that at all?
Yeah, when I included gender in the model, it was not significant, and also age was not significant. Not surprisingly, driving frequency, how often people report driving, was one of the biggest drivers, in addition to the mindfulness traits and impulsivity.
Okay, thank you.
Yeah, that was kind of a big surprise to me too.
Good morning, Johnny Lifshitz from PM&R. For the distracted driving, is there an opportunity to include it in driving school for those people that have moving violations and what have you?
I would love to do that. Driving school, and Dr. Hashikawa is here and could really speak to the trouble with implementing interventions in the driving space and the driving education space. A lot of what is out there right now is for profit, and so their goal is to churn and get people out on the road. So I would love to see that, but I haven't done it. we'll do a plug for the Calm app. After I did the study, I found that there's like at least a couple sessions dedicated to driving and mindfulness.
I have a question for Dr. Bretzin. So with the SCAT, there's those symptom clusters. Oh, I'm Lily Klein, by the way. I work at Michigan State University, so enemy territory. With the SCAT, there are like those symptom clusters. You have like cognitive fatigue, anxiety. Do you guys have any plans to maybe implement ways so that clinicians can see specific like types of symptoms that athletes are experiencing? And maybe if that might sort of provide some sort of benefit for college clinicians to be able to look at specific types of symptoms and maybe improve targeted interventions? Or do you guys just have regular SCAT-6? Is it just like all 22?
Yeah, what we are doing is asking about the SCAT-6 symptoms in total, which is 22 text messages that come all at once for a given athlete. And so thinking about how those symptoms cluster together over time is really important. I know Dr. Eckner's in the room, and we're doing more of how symptoms present initially and change over time and how those do relate to each other. What we're really finding is that these athletes are unique, and so eliminating some of those symptoms, you may be missing out on the full picture of the athlete overall. But I think that's a really good question and think something we should be looking into. But yeah, thank you.
Hello, my name is Karen Orr, I'm a physician assistant in surgery. My question is for Dr. Peterson. When you talk about the availability because driver training is private, have you thought of looking into the insurance claims by following the money for then ranking for better?
That's definitely been on the back of my mind for sure, for sure. Thank you. I was hoping to use this exploratory study to sort of launch that as a pitch, but we've got some work to do.
Hi, Avinash Chandran, Data Law Center. Dr. Bretzin, great talk. Just curious for your thoughts on how recoups might need to evolve over time, say to be sensitive to, or whether or not it needs to be sensitive to SCOT or child SCAT, especially as you're talking about maybe younger populations.
Yeah, I think just in terms of concussion management overall, we should be thinking about how to evolve over time. Just to give everyone an idea of what the SCOT is, it's a in-person clinical assessment that's done in the physician's office, and so certain providers have to be doing that. And the SCOT incorporates a multifaceted assessment, everything from background of how the injury happened, symptoms, balance and gait testing, as well as cognition. And it also does vestibular, ocular, motor. And so the SCOT is a multifaceted assessment where recoups is one key component of that. And so we might not necessarily have to do each of those assessments daily to make our decisions, but I think that's something we should be thinking of in the future. How do we do more of this remote assessment that's more multifaceted? What needs to be done daily? What needs to be done weekly type of thing? And to your question about the child SCAT, those that are below 13 are asked questions that are worded differently. So instead of asking someone if they're dizziness and they don't know what dizziness or fogginess is, they change the wording. And so what recoups is, it can be adaptable. You can use any words and any inventory that you want, which is really cool, and you can view those as a clinician. But I do think more of how we can include this multifaceted approach in our decision making should be thinking for the future.
All right, any last questions from folks you want? Yeah, please.
I have a question. I thought your work was very impressive, and I'm really interested in peer relationships, both for doing the training, if you've thought about peers, as well as when peers or others are driving with the participants. Have you thought about that in your work?
Yeah, I didn't spam everyone with the theory of planned behavior because that would have taken even more time. But social pressure is definitely a part of that. Unfortunately, this little facet only pertains to the perceived behavioral control and on that part. But I think There are some other research studies showing that gamification in the right way and good modeling and peer pressure can be a good tool for reducing distracted driving. In our qualitative work, because our questions were so pointed at the individual, nobody brought in their friends. Thanks for the great question.
All right, well, if we could give another round of applause for our speakers. A really nice example of the breadth of team science that's going on at the Injury Prevention Center. And I believe we have a break next, right, Nicole? So we'll have another 10-minute break for folks to network, get some additional refreshments, and hear about all the great work going on.